What's up, everybody, and welcome to this week's episode of the Well Man's Podcast. My name is Bryan Brosey. I'm joined by my friend and co-host, Keoni Tita. Keoni, how are you today?
Doing good. I'm really excited about our topic today. Spinal cord injuries.
Yeah, absolutely. So we wanted to kind of come on. I'm actually starting an internship, my final internship at PT school at a spinal cord injury day program, which basically just means an intensive therapy, physical therapy or other types of therapies for spinal cord injury patients. So really this topic is self-serving, but I want to do a little bit of a primer, just kind of go over some common things about spinal cord injuries and some common terms you may hear like quadriplegia, tetraplegia, what all these things mean.
Yeah, it's great because I don't get too much of this in my clinical practice at all.
Have you ever seen one, Keoni, clinically?
No, I mean I've seen hemiplegia. I've seen some paralysis and stuff like that, but it was never due to like a
SCI.
Yeah.
Okay. So overall, we'll start with what a spinal cord injury is. So spinal cord injury is defined as a traumatic damage to the spinal cord or nerves at the end of the spinal canal. So this affects conduction of sensory and motor signals across the site of the lesion. And spinal cord injuries break into a variety of different types of categories depending on which part of the spinal cord is affected. I'm not going to get into all of that, but you have different tracks that run through different aspects of the spinal cord. And depending on where your damage is, you can have different types of impairments, whether that be like you couldn't feel light touch, but you had muscular strength, that sort of thing. So it really just depends on where the injury is or the insult of the injury.
Okay. Some
quick stats on spinal cord injury overall. I just thought that these were interesting, and I'm reading these directly from physiopedia.com. So the estimated lifetime cost of a spinal cord injury patient is $2.35 million per patient.
Wow.
So a super, not only debilitating injury in your ability to make an income, but it's going to take quite a bit of money to medically manage the issue.
Right.
And according to the National Spinal Cord Injury Statistical Center, there are about 12,500 new cases of spinal cord injury each year in North America. And more than 90% of these spinal cord injuries are traumatic and caused by incidences such as like a traffic incident, violence like a gunshot wound, or sports or falls. And more commonly, it happens in males, about 2-to-1 ratio for males over females. Really what interested me and made me want to do my internship at that day program was the stories and the different types of goals that these patients have. So you're going from fixing someone's back pain to a 30-year-old who was sitting at a red light one day who got T-boned by a truck, and now their goal is to not have their mom have to live with them anymore, and they're 30-some years old. So it's just a
It's completely life-changing. And then I'll just add something. If you have a spinal cord injury, the spinal cord is not great at healing itself. Once you get injured, it just does not heal well at all. Whereas the peripheral nerves coming off the spinal cord into your arms and stuff, those nerves do tend to heal well. So the spinal cord injury can be devastating, especially if you have what I would term a complete spinal cord injury, where wherever that level is, everything below no longer functions because that spinal cord has been severed.
Yeah, awesome. And we're going to get right into complete injuries. But before we do, you essentially have a moment when someone has a spinal cord injury, and we kind of see this on football or in where we see a spinal cord injury in football teams. And I specifically, when I was going through PT school, I'm a huge Steelers fan. Ryan Shazier is a linebacker for the Steelers. And in my first year of PT school, he actually had a spinal cord injury and he has yet to play. So I thought it'd be super interesting. You can share the screen on here. And I just wanted to go through this and talk a little bit about spinal shock, which is what initially happens when you have a spinal cord injury. So I'm going to go ahead and share my screen here, see if I can even do that. Well, it turns out I can't do that, but okay. So if you look up like the video of Ryan Shazier getting a spinal cord injury, he was playing against the Bengals. You see he goes for a tackle, and then immediately he has this just loss of motor function in his legs, and he basically just goes flaccid. That's because when you do have a spinal cord injury, you typically go through spinal shock immediately. And this is what Ryan Shazier was demonstrating. You can kind of see if you look up the YouTube video. And you see a complete loss in spinal shock. You see a complete loss of reflex activity below the level of the injury.
And that's immediate, right?
And that's immediate, and they're immediately flaccid. That's why I thought it'd be super interesting to share that video, because if you do see it, he goes in for the tackle, and immediately he just starts, he kind of is like squeezing a fist in his hand, and you can tell he just can't move his legs at all.
Wow.
And he's, completely flaccid. And so at that point, just from seeing how he's acting, that it's at least a lower level injury. Like, it's not a cervical one affecting his arms.
Because he's moving his hands, right?
Exactly, because he's moving his hands. But so when you get that spinal shock, you see immediately a loss of reflex activity below the level of the injury. That's where you see this kind of flaccid paralysis below the level of the lesion. So if you're looking at Ryan Shazier, that's his legs as he's laying there. And typically at this point, a person is also going to lose bowel and bladder control, because that's controlled further down the chain in those sacral segments. So that's a big portion of spinal cord injuries and managing bowel and bladder function. And towards the end of spinal shock, you may see more of like an increased spasticity, which would be the opposite of flaccidity or flaccidness, where they're kind of getting super rigid muscles. And you may see that, and that would actually be a positive sign as coming out of spinal shock. So it'd be a good thing.
Is that a positive sign also for like stroke injuries and stuff like that, with the muscles get rigid sort of?
Well, I know with stroke injuries, you can have like synergies where you can have these rigid muscles and it's not necessarily a proper firing pattern. So I think they're two different ways that they go about impacting the body. The immediate medical management. So immediately with Bryan Shazier there, you're going to focus on managing the vertebral damage. So putting them in some sort of like, some sort of a binder or some sort of thoracic brace or cervical brace, some sort of spinal collar, just to monitor that the vertebral damage and immobilize that. And then also, depending on where the lesion is, you got to think about breathing control, respiration, and maybe if the diaphragm's affected and things like that, the accessory muscles that are going to help you breathe could also be impacted. So you need to all these things are going into account.
Right.
But there's a huge classification scale. It's called the International Standards for Neurological Classification of Spinal Cord Injury. And it's basically the American Spinal Injury Association. So we shorten it to the ASIA scale. So when you hear about spinal cord injuries, often they say, what's your ASIA score, or where are you on the ASIA scale? And I'm going to kind of go through that, because that allows us to have a knowledgeable conversation about the person's spinal cord injury, essentially.
Okay.
So before we get into that, obviously you can have, you mentioned it, paraplegia and tetraplegia. So paraplegia is loss of motor or sensory. So either or, or both, depending on where the injury is and what it's affecting. Paraplegia, you can have loss of motor or sensory function in the thoracic or sacral segments. So this one, typically the person has their arms available for use in paraplegia. In tetraplegia, we have impairment or loss of motor and sensory function in the cervical segments, and then the lower segments as well. So tetra meaning 4, we're typically affecting the 4 limbs. Paraplegia, we're typically affecting the 2.
Yeah.
And then further on in the ASIA scale, and you mentioned this as well, Keoni, you have the complete versus the incomplete injuries. And a complete injury means you have absence of sensory and motor function in the lowest neural segment. And so what is that lowest neural segment? For lack of better terms, your butthole, whether that be an anal wink or sensation in that region. And so you have to look at all those sorts of things for a spinal cord injury to actually determine if it's complete or incomplete. So the big thing there is just, is it the entire spinal cord that's affected after the level of the injury? Or is it just incomplete, which is some level of preservation below the neurological level of the injury? And this typically does come with a better prognosis, and you can see how.
So it comes with a better prognosis if you have that sensation, right? Where you can.
Yeah, if it's incomplete. And I mean, that makes sense. If you have zones of preservation that you can still use, it's more than likely less of a injury.
Right.
And I'll certainly be learning more about this and the prognosis factor of it overall. And then there's the skeletal level and the neurologic level. So in the ASIA scale, everything is decided based off the neurological level, which is how we truly classify the ASIA scale. And this refers to the lowest segment of the spinal cord with normal sensory and motor function on both sides. So this means a person can feel and also contract their muscles voluntarily below or at this level, and that's the neurological level. So if someone says, I'm a T9 Asia A complete or incomplete, Asia B incomplete, then you know that if it's at that T9 level, and if they're incomplete, then they have some level of preservation or some sort of, whether it be sensory or motor, below that T9 level. And we know that all these different nerves at these various levels go and innervate different things, and we can use that to dictate and find out basically what the person's going to have available to them and what they can use. So that neurological level is basically how we're putting people on the ASIA scale, and that's the level we talk about when people say, I'm a T9 or I'm a C7 or that sort of thing. They're talking about the neurological level, as opposed to the vertebral level or the skeletal level, which is just where that damage is found on that vertebrae. So if someone falls and they break their C7 vertebrae, it doesn't necessarily mean that they're a C7 spinal cord injury.
Okay.
So a therapist or medical provider to determine that ASIA scale is going to test sensory and motor, like I've been saying. And that sensory component would be sharp dull, which is that spinothalamic tract. So I talked about how there's different tracts that feel and interpret different things. And that can dictate, or that can kind of tell you about where the injury actually is and what it's impacting. And you're going to look at light touch, would be the dorsal column medial lemniscus, which is more in the back of the spinal cord. And then again, that deep anal sensation is the only way to tell if you are a complete or incomplete sensory spinal cord injury. And then as well with motor, you test the muscle strength of all the muscles, and those are grouped. Now, it's important to know, I did say, like for the neurological level, that you're looking for normal sensory and motor functions on both sides. And normal just means they can move it against gravity. So this isn't necessarily a previous level of strength, or that it's normal strength even. It just means that they can voluntarily contract it against gravity. So even there's still way more work to be done.
Right.
Way more strengthening to happen.
Right.
And then as far as the ASIA scale, like I mentioned some letters there when I was talking about the ASIA scale. So you can have A, B, C, D, or E. And then A is a complete injury, and I went through that. So that just person would be an ASIA A, and they would have a complete injury, and that would just mean that the whole spinal cord below the level of injury is affected.
Typically with a poor prognosis.
Yes, exactly. Then a B, which is, and these are basically going in reverse order. So A, B, C, D, E. E is normal. So we're working our way up to a more not normal, just the typical previous to the injury. Abilities. And so an A is complete, like I mentioned, and then the B is incomplete, but this is where we have sensory but not motor preserved at the neurological level of injury. So here they may have sensation, they may be able to feel some sort, whether it be cold, hot, pressure, depending on what type of the injury it is, they may be able to feel that, but they're going to have motor function loss below the level of the injury. So again, if they say, hey, I'm a T9, they may have, for instance, weak legs. That would be a little bit lower on the spinal cord. Okay. And then a spinal cord injury of a C is also incomplete, but now we have just basically more muscles available, or we have muscles available to us below the neurological level of injury. So here most of the muscles have a grade of less than a 3. And what that just means is that they're unable to contract fully against gravity. So here you may see like a small twitch response, where you just may be able to palpably feel a contraction, but it's not producing much movement. Whereas with a D, and again, we're getting better here, the motor function is preserved below the neurological level of injury, and most of these muscles have more than a 3. So they're able, or more than 50% of the muscles are 3 or more, which allows you to move at least against gravity, if not more. And then the E is just normal. So pre-spinal cord injury. So again, A through E, with E basically being the better side of the spectrum, and A being the worst complete side of the spectrum.
Okay.
So that's just useful as, someone's going to say, I have a T9 Asia B, and that just means that the person had the injury to their spinal cord at the T9 level. And then based off all the nerve innervations, we can know how that affects them. And then if they said it was a B, then we know it's an incomplete injury, and they may have some sensory functioning below that T9 level.
Okay.
So it's really useful just for our ability to kind of communicate and go
Right.
into what.
Yeah. Classify and get an idea of like what you're in for, right? Both as the healthcare provider and the patient.
Exactly. And so of particular note for spinal cord injury patients, the level of the injury, of course, and then what that's going to impact and what type of injury. Like I mentioned, depending on what tract or what area of the spinal cord it impacts, that's going to impact how you're impacted greatly. So that's a huge deal. Respiration, bowel, bladder, pressure ulcers. So again, all dependent on the level of the injury and the level of the impairment. But if you can't, use Ryan Shazier, we'll just say with that example, if he can't move his legs and he's sitting in a wheelchair consistently and constantly, you're going to have to certainly watch out for some pressure ulcers, those sorts of things where you get some skin breakdown. And then just managing the fact that you're no longer doing that motion as lotion and you're no longer able to do motion as lotion on your own. And that can go all the way to affecting your bowels if you can't control those, depending on where your injury is.
Right.
And then function, moving, sex also. So everyone is affected differently as far as sexuality. And I think that's super interesting with a spinal cord injury. As far as male fertility goes, only about 6 to 8% of spinal cord injury patients can ejaculate, and they typically have a low sperm motility and sperm count. With females, we find that there's no change in fertility overall, but they do have a risk of what's called autonomic dysreflexia during pregnancy. So autonomic dysreflexia is something, I'm not sure if it's 100% specific to spinal cord injury patients, but it's very big for spinal cord injury patients because it's essentially if there's some sort of insult or something that's aggravating them, and not emotionally, but like tight clothes, for example, and you can't remove them, they can go through autonomic dysreflexia, which is essentially you see like your blood pressure increase, they get feelings of anxiety, that sort of things, and this can become it is a medical emergency. And so if someone has a spinal cord injury and they're and they're pregnant and they're giving birth, that would certainly classify as one of those insults like tight clothing.
And
you're having all those symptoms, and that's a medical emergency that you have to manage. So that's a super big thing of managing, kind of knowing what to do in these instances, and also being able to manage them at the time. So if someone does have autonomic dysreflexia, and again, this is when a noxious stimulus below the level of the lesion triggers some excessive sympathetic response. So that's where the person's going to have like a pounding headache, increased blood pressure. They're going to feel anxious, like I mentioned, maybe chills, maybe they're sweating. The biggest thing you want to do is sit them up and keep them up and then search for that source of irritation. And then it's a medical emergency. So depending on where you're at and who this is for, you would want immediate medical attention.
Wow, that's fascinating. So the spinal cord comes down to what? Like when L1, we look at the end of L1, right? L1?
Yeah.
Okay. So any spinal cord injury that you have, am I right in saying that it's going to affect your, urogenital function somehow?
Yeah. I mean, at this point, I don't know enough to stake my claim on it, but I guess, yeah. I mean, it makes sense to me.
I would think you're in for that if you have any type of spinal cord injury.
And again, it really depends on what, and maybe you can't feel to get an erection, but you have the motor control to hold your bowel, your bladder.
Yeah.
So it again depends on what type of injury that you had and what portion is affected.
Mm-hmm.
And then, but I would imagine, yeah.
So when you're seeing patients like this, Bryan, how are you managing them? I imagine it's a lot of like making sure you're getting that motion is lotion thing, right? I mean, are you taking them through like passive motion, trying to get them to use their muscles?
Yeah. So I know immediately, you will, like in the immediate term, it's a lot of passive range of motion. What's interesting about being in the day program, which I haven't started just yet, but it has like the exoskeleton type suit. So you do a lot of functional electrical stimulation where you basically like a TENS unit, if anyone's ever used that.
Yeah.
But you can also use you can use a TENS unit to reduce pain, and you can also use a TENS unit in a different way to actually get the muscle to fire. And we could do that with a spinal cord injury patient to actually facilitate some of these gross motor movements. So I don't know if you've seen, Keoni, there was a video that they did, and I saw it in college, where they removed the head of a cat and put it on a treadmill, and the cat would walk without its head, because they call it, in the class I was learning, they called it gross motor programs. And these gross motor programs are stored within the spinal cord. So the cat gets the feedback of the moving treadmill, and the reciprocal walking gait pattern is so programmed that it just follows the treadmill feedback, essentially. And that feedback and the information from the treadmill doesn't need the brain. It just needs to go to the spinal cord, where the spinal cord can say, okay, I feel these movements and I produce this movement. And you do some of that with this functional e-stim.
So when you're doing the e-stim, though, how are you stimulating the spinal cord?
So you wouldn't be stimulating the spinal cord, you would be stimulating the actual muscle. So it would be
it's just like a regular e-stim then. It's just
in that regard. So it would be like the person's on a bicycle, and we're essentially having a firing pattern of these pads that are on their legs that help facilitate bicycling. Without them doing it. And this is a lot of stuff I haven't seen yet that I'm going to see a lot of. And that's one of the reasons I'm so excited about this location, because it's going to be, they have, like I said, they have like that exoskeleton suit. You do a lot of treadmill training, which is using basically that principle that I just broke down with the cat. I'm here. So it's almost like you build it. And even from that line of questioning, it's not like you treat the spinal cord, you treat the muscle and hope that they eventually, I guess, meet in the middle. It's kind of how I understand it right now, but I'm certainly going to get a better understanding in the future. Does that make sense?
Yeah, it makes sense to me. It's just, I guess you'll find out. I don't really know, but the spinal cord is just interesting to me, because it seems like it doesn't have a whole lot of healing capacity. But then you also hear these amazing stories where people are told they're never going to walk again, and lo and behold, they're actually moving again and walking. Yeah. So it's always fascinating to me, like, why does that happen if you see a complete, destruction at a certain level, and then some people are actually walking? It makes me think that, I don't know, maybe thinking about the movement itself, even though you can't move, at least initially, and trying to get yourself back on your feet, so to speak, just thinking about the movement and imagining the movement, kind of like what athletes and musicians do when they can't actually play. They imagine themselves playing, and it seems like, I wonder if that's just helping regenerate some of the nerve and the healing that goes on in the
And I think you would be practicing that gross motor pattern. And I know they did a study with stroke patients where they had that hemiparesis on that one side. So you have like a weak arm, essentially.
Right.
And they would do, I can't remember what it was in the study, but like curls or something like that. And they would do it on the strong arm, and they would imagine that they were doing it with the affected arm, and the affected arm saw strength gains just from the imagination of it.
Right.
So I think that goes and speaks for both these gross motor programs, and just that there is definitely some sort of mind muscle connection that we're working on, and whether that needs the brain, the spinal cord, or the peripheral nerves, or where amongst the pattern of transmission that gets broken up, that we can further develop. And it's something I definitely don't fully understand now, that hopefully I'll get a better understanding of. But as far as I know, like, a complete spinal cord patient is never going to be fully better.
Right.
That's as far as I know.
At least with what we have right now. I mean, you mentioned exoskeleton, that you have one at that clinic. I mean, it sounds like that is something that can really help some of these people, where they can move if these things become mass marketed, the exoskeletons. But also, I'm really interested when you get into about stem cell stuff for healing spinal cord injuries and stuff, because from what I've understood, in some animal models, they have completely healed some, and I could be wrong about this, but they have completely healed some complete spinal cord injuries in like mouse models and stuff.
Okay. Yeah.
So I'm, that's
Yeah, neither of
fascinating
us are
to me.
experts.
Yeah, no, that certainly not, but that certainly gives a lot of level of hope. And the other thing that I think is interesting, especially with hemiplegia, is where, you know, one side is paralyzed, and, you know, either from a stroke or whatever, maybe a spinal cord injury, but what the patients invariably do, which is, you know, the common sense thing to do. Well, if you can't use your left arm, then you're going to start doing everything with your right arm. And I would think in the initial treatment phase, you kind of want to tie your good arm back so you don't use it, you know, and try to really focus on using the bad arm, because if you're constantly using the good arm, then you're talking about you're just not firing those nerve pathways from the brain to the CNS out to the limbs and back. So do you have any thoughts on that, and from PT or PT school, or is that even worth even doing?
Yeah. So one of the biggest things, because at this point I'm teaching this and talking about this from the standpoint of I basically took my neuromuscular 3 course and I'm ready to go to this internship. And the big thing in that neuromuscular 3 course, when we would have a practical or something like that for spinal cord portion of it, was, are you focusing on recovery or compensation? And so I think that's a huge topic, and that's why you have to run through this Asia scale, complete versus incomplete, what is available, and all these terms have to be understood so you can understand, should you be going for recovery? Is that a possibility? Or are we at a point where maybe the person is a complete injury and now we have to teach some compensatory movement strategies to actually get the person to be as independent as possible? So that person that really doesn't want their mom to live with them, you know, at this point, how do they get into the shower without the use of their legs?
Right.
Do that by themselves. But then at the same time, if the person has an incomplete injury, we might do more of a recovery-based focus where we're going to use those legs and try and strive, you know, really, really work those legs in hopes that we get more recovery out of it. But as far as I know at this point.
Yeah, we have to talk about this again. Any spinal cord injury, though, you know, is best going to be treated by seeing a PT, right? I mean, honestly, I wouldn't, if somebody came into me with this, I would certainly look to a PT as far as how I can, you know, comprehensively treat them along with the PT stuff. But I'd imagine most spinal cord injury people should be referred to a PT, right?
Yeah, absolutely. And, you know, after that immediate medical management, absolutely.
Yeah.
Absolutely.
Because there's so many, so you mentioned there's so many, first of all, your lifestyle is going to completely change. I mean, it's life changing. And then there's a mental, emotional aspect to it.
Yeah.
Like, you know, some people I'd imagine initially would have a hard time coping. You know, you're driving in your car, you get in a car accident, and all of a sudden you find yourself, you know, 2 days later or 3 days later where you're paralyzed.
Yeah.
You know, and
all of a sudden your wedding in 6 months, you're not going to be able to have sex with your wife.
Right.
And it just,
it's stuff like that.
You
You can't use the bathroom on your own.
Right.
Right. So you completely, you know, that's a huge thing. So you know, as far as like providing like healthcare and help for these people, there's a lot. I mean, it seems like there'd be a lot of like mental, emotional, maybe counseling, stuff like that has to go through that, or getting involved with groups with people that have been through it, who have actually gone through it and can cope with that life change. So there's a big mindset thing that has to happen.
Yeah. And so I joined, when I found out I got this internship, I joined some spinal cord injury Facebook groups, and that would be something I would recommend. I mean, that stuff's amazing. You see people even on Christmas Day sharing their stories or videos about now they can move their pinky, that sort of thing, or the discussion of stem cells and alternative therapies with it. And these are all patients. So it's super interesting just to sit and kind of, I guess, more or less eavesdrop on these conversations. But I know like you were saying, it's a huge part. And I think that's one of the benefits of like the program that I'm going to is I think more or less I see somewhere in the realm of like 5 to 8 patients, and those specific 5 or 8 patients every day. And so it develops a little bit more of a community like that. And I think that stuff's huge. And that's why I felt like you have to mention stuff like sex. Cause I mean,
Yeah,
I just
it's a
put
huge
myself
part.
in that shoes and you can't imagine.
No, absolutely. I mean, that is, that's something, hell, that's something that partners should be talking about anyway. I mean,
Mm-hmm.
honestly, but especially when you lose function, is how you're going to get on with that. That's a huge part of anybody's relationship, and how you're going to deal with that and go about, having that intimacy with a spinal cord injury. Yeah, it needs to be talked about. It needs
Yeah.
to be.
And now that I have a little bit more to digest it, as far as the overall management, I think it really medical management has to be really, really comprehensive. So I obviously supporting physical therapy, but at the same time, depending on where that injury is, a speech therapist may be the most important,
Right.
depending on how seriously what level the injury is at and what that's impacting.
Right.
And that can be huge. And I mean, imagine if you're having trouble breathing. I mean, obviously that's the most important. And then occupational therapists are typically known for their proficiency in dealing with the upper extremity. So depending on if it's cervical and it's impacting your arm, they could certainly help you more with those fine motor skills with your hand. And a PT can certainly help and hope so you can walk again and that sort of thing. But I know that the therapy, as far as physical therapy goes, is a lot of functional training and working on locomotion and can you walk and that sort of thing. And then it's really that discussion, and I'm going to get a lot better at this, but that discussion of compensation versus recovery. Mm-hmm. Is a person going to be able to walk without orthotics on their, locking their knees out the whole time so they can swing and basically stand on their ligaments? Or will they have voluntary control of their quads ever again? So that all that it's fascinating, and I'm excited to get started.
Do you have any idea on like what the life expectancy is of somebody with spinal cord injury? I mean, I'd imagine you're going to be much more prone, if you're not careful, to infections, right? Like I'm specifically talking about like bed sores, not being able to move your muscles. I mean, it seems like you would be, and pressure sores and things like that.
Yeah, absolutely. So all that I know is off the top of my head is that life expectancy definitely decreases for all individuals with a spinal cord injury.
But do you, okay. I would really be curious to know the reason why. I would think it's due to secondary stuff.
Yeah.
Like,
I mean, that makes a lot of sense.
Yeah, I wouldn't think it's due to the injury itself. It's just due to what the injury has done. So it seems like there's as the person with the injury, there's a lot that you have to do to be aware of to keep yourself busy. That the fact that we move, I mean, that's what keeps us healthy, right. And if you're limited in that, you really have to make sure that you are moving or getting passive movement, and you're changing your body positions and things like that.
Well, immediately goes to now you're managing your entire life in just such a different way. Like you're saying now, and you can YouTube just people's routines for getting ready in the morning. You can YouTube like C4 tetraplegia and morning routine. And it's a 35-minute video of a kid who's my age, 26 years old, getting dressed by his mom and going through the morning routine. And it's taken forever. And you can just only imagine.
Yeah. And you mentioned the injured, like the causes of injuries. Is it motor vehicle accidents are the number one cause? And that's the number one cause?
From what I know, motor injury.
And gunshot wounds is that up there too?
Yep. So typically it's caused from, typically traumatic. So traffic accidents, violence, sports, or falls. And that's the majority
of them. And the sports are what?
90%.
So are there sports that stand out with this? Because we mentioned football, but is that a main sport for this, or do you even know?
I haven't looked up any research.
Because it's rare. Specific. I mean, it's rare. It's rare at all levels of getting a spinal cord injury from football, but it can happen.
Well, what's nuts
contact
is
sports.
I feel like every 3 or 4 years, there's a spinal cord injury in football that I see, at least. That's what I feel like is crazy. Because I
Well,
remember that Ryan Shazier thing that happened 2 or 3 years ago, and
yeah.
I feel like everyone I can't remember his name, but he went to Rutgers, and that was like a huge story here. He was on a kickoff or something like that, and the guy never walked again. And now he brings Rutgers out onto the field occasionally in his chair, and it's just
Wow.
super. I feel like that's something I hear about every 3 years or so in football, but I have no signs to back that up or research.
Right. Well, it's for spinal cord injuries relative to other sports, I would think it's a high risk sport for that.
Yeah.
I mean, not to mention, all the hits to the head that you're getting also, but that can affect the brain. Like we're seeing a lot of stuff now with like the amount of concussions people get, which football players tend to get quite a few. And then what it does to you later on in life. But
yeah. I was watching a video right before this podcast about a person who had a spinal cord injury, and they fell off a rock while climbing a mountain. So and then it fractured. I think it was C6 or C7. And so you have maybe some use of your hand, depending on if it was C6 or C7, what's going on there. But again, you're hiking with your friends, you've slipped off the rock, and your life has forever changed. It's completely nuts. But then that guy, he ended up walking.
Yeah.
So I want to definitely, and we'll do a podcast on that when I get more knowledgeable just about the prognosis.
Yeah, I would like to, because for me as a functional medicine or natural med doc, that I always think about like what are things that are going to help the nerves repair. Not a lot of great research on it, but there are certain nutrients that seem to be like food for the nerves. So we're talking about like fish oils, phospholipids, glycerylphosphocholene, these types of things. These things may help. So in some studies they can help. So as far as a comprehensive approach, I would just put that in there. It certainly wouldn't be a foundational thing, but it may help.
Yeah. It makes sense with the myelin, especially for other things too.
Right.
Just being all fatty. But really, that was just a primer. As you can tell, I'm getting excited, but hopefully I can speak from a more knowledgeable
really cool
place.
Yeah, it's really cool. I mean, that's something I totally had no idea about, but yes, now I feel like I could speak the language a little bit better.
Yeah. Well, all right, everybody. Thank you for listening. We look forward to speaking with you next week. And until then,
take care.